The following podcast is part of a certified educational activity titled New and Emerging Therapeutic Strategies in Bladder Cancer, Updates in Early Stage Disease and Beyond, featuring Dr. Matthew Galsky from the Icahn School of Medicine at Mount Sinai Tisch Cancer Institute in New York. Access the entire activity and complete the post-test at peerview.com/MHH. Additional resources are also available.
Hello, and welcome to New and Emerging Therapeutic Strategies in Bladder Cancer, Updates in Early Stage Disease and Beyond. I'm Matt Galsky from the Icahn School of Medicine at Mount Sinai in New York. Today we're going to be talking about a number of advances in the treatment of bladder cancer, including immunotherapeutic strategies, targeted strategies, and antibody drug conjugates across the range of clinical disease states of bladder cancer. So let's begin. We're going to start by talking about early stage bladder cancer, where there's been a lot of activity in the development of therapies both for non-muscle invasive disease and muscle invasive disease. Perhaps non-muscle invasive bladder cancer represents among the earliest disease settings where an immune checkpoint inhibitor is currently approved by the FDA. Pembrolizumab is approved for the treatment of patients with BCG unresponsive carcinoma in situ of the bladder based on the KEYNOTE-57 study. And we've seen various presentations of the KEYNOTE-57 study with updated results over time. And here you can see the latest update demonstrating the durability of responses with pembrolizumab in this patient population. Remember, the standard treatment for patients with BCG unresponsive disease historically has been radical cystectomy. So if radical cystectomy can be delayed or prevented, that's certainly an advance in terms of patient management. Here you can see the duration of response in patients receiving pembrolizumab for BCG unresponsive non-muscle invasive bladder cancer. And of note, you'll see that the duration of response or the durability of responses is achieved only in a subset of patients initially achieving a complete response to treatment. However, that percentage of patients is quite similar to what we see in terms of the response rates with immune checkpoint inhibitors in later stage bladder cancer. That is, around 20 to 30% of patients achieve a durable response to treatment, and you can see many patients out beyond 18 months still in a complete response. So certainly in those patients, the delay of cystectomy can translate into a meaningful benefit. Here we see the results from a similar study that was conducted through the SWOG Cooperative Group. This is a study of atezolizumab in patients with BCG unresponsive non-muscle invasive bladder cancer. And here we see results from two cohorts of patients. Remember, in KEYNOTE-57 also enrolled two cohorts of patients with carcinoma in situ, and then patients with high-grade papillary tumors or high-grade T1 disease. In KEYNOTE-57, we haven't seen the results from the latter cohort yet, and so important results we're seeing here from the SWOG study. In the SWOG study in patients with carcinoma in situ, pretty similar results, although smaller patient numbers, pretty similar results in terms of the likelihood of a complete response and the durability of those responses. Here you can see event-free survival in patients with high-grade TA or T1 disease, demonstrating an 18-month event-free survival rate of 47%. And so certainly this does seem to be potentially a strategy for a subset of those patients as well. Moving on to muscle invasive bladder cancer, there has been an attempt to develop strategies over time that allow curative intent therapy to be delivered to patients with muscle invasive bladder cancer and yet let them retain their bladders. And that strategy has largely revolved around the use of chemotherapy concurrent with radiation based on the results of the BC 2001 study, which demonstrated that chemoradiation compared to radiation alone was associated with a significant improvement in local regional disease-free survival. Building on that strategy has Building on that strategy is important in that there are a subset of patients who are unable to receive chemotherapy, and certainly even though the results with concurrent chemoradiation are favorable in a subset of patients, not all patients are cured with this approach. One strategy for integrating immune checkpoint blockade with radiation for the treatment of muscle-invasive bladder cancer is to use standard chemotherapy, and gemcitabine has been used as a radiation sensitizer with radiation historically. And so we saw a very interesting clinical trial presented at ASCO where gemcitabine was administered as the radiation sensitizer, pembrolizumab was administered as an immune checkpoint inhibitor, and radiation was administered. And this strategy was used to try and establish a curative treatment for bladder cancer that allowed sparing of the bladder. Here's the treatment schema for this trial. Patients underwent a single dose of pembrolizumab first, followed by another transurethral resection of bladder tumor. That was done both for clinical purposes but also for biomarker purposes to understand the impact of treatment with one dose of PD-1 blockade, and then patients received the combination strategy followed by an additional transurethral resection of the tumor bed to determine the response to treatment. Here you can see the results of the study in terms of the 1-year outcomes, and you can see that the 1-year estimated bladder attack disease-free survival was 88% in this data set. The follow-up's relatively immature at 1 year, however, very promising thus far in a strategy that has been moved on to larger randomized phase 3 studies. We also saw the results of a study that removed chemotherapy from the treatment regimen and focused on a doublet immune checkpoint blockade regimen given concurrently with radiation. That is the combination of PD-1 blockade with durvalumab and CTLA-4 blockade with tremelimumab. That was administered every 4 weeks for 3 cycles with radiation therapy, and then after that treatment, patients underwent a restaging transurethral resection, and if there was a complete clinical response, then patients proceeded with surveillance, and if there wasn't, then a radical cystectomy was recommended. And with this approach as well, we see a complete clinical response rate of 81%, and we also see a bladder intact disease-free survival at 12 months of 73%. So we're seeing relatively similar numbers in these studies despite somewhat different patient populations, somewhat different study designs, suggesting that with radiation integrating immune checkpoint blockade, this does seem to be a feasible approach and lead to bladder intact disease-free survival, at least based on the maturity of the follow-up of the data thus far. So these are both strategies to watch as larger randomized phase 3 studies are already being initiated and being planned. Another approach to consider in terms of bladder sparing is whether or not transurethral resection of bladder tumor plus systemic therapy alone can achieve durable disease control with an intact bladder without the integration of additional local therapy. Why would that concept be considered? Well, we know with neoadjuvant cisplatin-based chemotherapy that around 30% of patients will have a pathological complete response. And so we know it's possible to achieve eradication of cancer in the bladder with transurethral resection plus systemic therapy. And the question is, can we identify which patients have achieved that outcome without having to remove the bladder? This is a concept that's been considered for many years, but there have been barriers to integration of that strategy into a standard treatment paradigm, namely that it hasn't been explored adequately prospectively, and it hasn't been explored in a rigorous fashion. We initiated a study several years ago testing this concept where patients with clinically localized muscle-invasive bladder cancer received 4 cycles of standard cisplatin-based chemotherapy, gemcitabine and cisplatin, and we integrated the immune checkpoint inhibitor nivolumab. After 4 cycles of treatment, patients underwent a restaging evaluation, which included imaging, a cystoscopy, biopsies, and urine cytology. And if all of that testing was normal, patients had the option to proceed without cystectomy. And if there was evidence of cancer on those specimens, then a radical cystectomy was recommended. Follow-up on this study is approximately 1 year in terms of the median follow-up. 76 patients were enrolled. At the time of the data lock, data for the post-cycle 4 restaging was available on 64 patients. 31 patients had achieved a stringently defined complete clinical response. Among those patients, 1 patient opted for an immediate cystectomy and had a low-grade papillary tumor at the time of cystectomy. The remaining patients opted for additional immune checkpoint blockade with nivolumab for 4 more months, followed by surveillance as per protocol. And of course, the patients who did not achieve a complete clinical response were recommended to undergo cystectomy. Here is the swimmer's lane plots demonstrating the outcomes of the 31 patients who achieved a complete clinical response and opted not to undergo immediate cystectomy. And you can see here in the bars in blue the patients who have experienced a recurrence, with the blue dots indicating a local recurrence, the green dots indicating radical cystectomy being performed, and the red bars indicating no evidence of recurrence. And you can see a number of patients out beyond 1 year without evidence of recurrence, with bladders intact, demonstrating that there is the possibility to achieve long-term bladder intact disease-free survival with this approach, although longer follow-up is certainly needed to determine the durability of these responses. The other adjuvant strategies integrating immune checkpoint blockade for muscle-invasive disease that have been explored recently have revolved around patients who have already undergone cystectomy, determining whether or not administration of immune checkpoint inhibitors can decrease the likelihood of metastatic recurrence at patients deemed at high risk for recurrence. And there have been 3 randomized clinical trials exploring this concept. IMvigor10, which randomized patients to immune checkpoint blockade with atezolizumab versus observation. Checkmate 274, which randomized patients between adjuvant nivolumab and placebo, and the ongoing Ambassador study randomizing patients between pembrolizumab and observation. IMvigor10 has been reported, Checkmate 274 has been reported, and the Ambassador study is ongoing. These studies were designed very similarly, but there are some nuances. The trials have included, in general, the same patient populations, which have included patients who had received prior neoadjuvant cisplatin-based chemotherapy, but had residual cancer at the time of cystectomy or nephroureterectomy that is pathologic evidence of T2 disease or higher, or pathologic evidence of nodal disease, or patients who hadn't received neoadjuvant chemotherapy but had pathological evidence of T3 disease or higher. Here you can see the results of IMvigor10. Disease-free survival was the primary endpoint, and there was no difference in disease-free survival in this study with adjuvant atezolizumab versus observation. The Checkmate 274 study, again, similarly designed, however, randomizing patients between nivolumab versus placebo. And in this study, there were co-primary endpoints, disease-free survival in the all-comer population and disease-free survival in the subset of patients with tumors harboring high levels of PD-L1 expression. Here you can see the results of the co-primary endpoints of Checkmate 274. In the overall population, adjuvant nivolumab was associated with an improvement in disease-free survival compared to placebo with a hazard ratio of 0.7. And in the patients with tumors harboring high levels of PD-L1 expression, And remember, this approach uses the 28-8 assay for PD-L1, staining tumor cells with the cut point of 1% or greater as PD-L1 high. And in patients with tumors harboring high levels of PD-L1 expression, nivolumab was associated with an improvement in disease-free survival compared to placebo with a hazard ratio of 0.53. With an adjuvant therapy, of course, the safety of treatment compared to a setting where the standard has been observation, safety is of critical importance. The adverse event profile with adjuvant nivolumab versus placebo was reported, and you can see the results on this slide. There was a higher likelihood of treatment-related adverse events with nivolumab versus placebo. The grade greater than or equal to 3 adverse events were 17.9% with adjuvant nivolumab and 7.2% with adjuvant placebo. The disease-free survival endpoint of Checkmate 274, the primary endpoint, has raised the question whether or not disease-free survival is an important clinical endpoint in this setting. Of note, overall survival is a key secondary endpoint of the study. The overall survival endpoint is event-driven, and the number of events have not yet been reached to do that analysis. However, one way to look at disease-free survival as an important endpoint is to see if this is associated with other clinical manifestations of disease, and quality of life assessments were collected in the context of Checkmate 274. So at ASCO this year, we presented the results of the impact of recurrence on quality of life in patients in this data set. And as you can see here, quality of life in patients who experienced a local recurrence, but more importantly, a distant recurrence, was decreased compared to patients who didn't experience recurrence. And so this is one piece of evidence suggesting that delaying or preventing recurrence can be an important endpoint to achieve in the adjuvant setting. The other clinical disease setting that immune checkpoint inhibitors are being explored is in the neoadjuvant setting in patients with muscle-invasive disease. We know that neoadjuvant cisplatin-based chemotherapy is associated with an improvement in survival and is a standard of care, yet patients who receive neoadjuvant chemotherapy followed by cystectomy still have a relatively high risk of recurrence, and patients who are ineligible to receive cisplatin-based neoadjuvant chemotherapy don't have good neoadjuvant systemic therapy options, raising the question whether or not there's a role for immune checkpoint blockade in this context. Here you can see a number of phase 2 studies which have explored single agent or doublet immune checkpoint blockade in the neoadjuvant setting. These studies were designed somewhat similarly. However, the patients that have enrolled on these studies have been slightly different in terms of the clinical stage of disease, with some of the studies enrolling a bit more patients with clinical T2 disease and others enrolling patients with a little bit more advanced T-stage disease. That said, the pathological complete response rates on these studies are relatively similar and not too dissimilar from what we've seen with chemotherapy in this context in the past. And based on that, and based on the safety of administering immune checkpoint inhibitors in the neoadjuvant setting from these data sets, these strategies have been moved forward to the randomized phase 3 setting. There have also been a series of phase 2 studies testing cisplatin-based chemotherapy plus immune checkpoint blockade in the neoadjuvant setting. And here we see complete pathological response rates, which seem a little bit higher than what we expect to see with cisplatin-based chemotherapy alone. And these strategies as well have led to randomized phase 3 trials trying to integrate chemotherapy plus immune checkpoint blockade into the neoadjuvant setting. Here you can see the overall schemas of these phase 3 trials. in both cisplatin-ineligible patients where immune checkpoint inhibitors or immune checkpoint blockade combinations are being explored, and that includes the combination of enfortumab vedotin, the antibody drug conjugate, plus pembrolizumab, or the combination of nivolumab plus the pegylated IL-2. In the cisplatin-eligible patient population, a number of phase 3 studies being performed testing gemcitabine plus cisplatin plus a PD-1 or PD-L1 inhibitor versus standard gemcitabine and cisplatin as neoadjuvant chemotherapy. So integrating all this data in the muscle-invasive bladder cancer setting into a patient case. This is a 58-year-old man who initially presented with hematuria but good renal function, had a cystoscopy and imaging revealed a bladder tumor, was diagnosed with clinically localized muscle-invasive urothelial cancer of the bladder, received treatment with 4 cycles of gemcitabine plus cisplatin, underwent a radical cystectomy, and surgical pathology revealed a PT3N1 tumor. And so what treatment options would be available for this patient with this pathology finding after receiving neoadjuvant chemotherapy? Historically, patients in this setting were observed despite a known high risk for recurrence. There had been no definitive data suggesting that administration of additional systemic therapy in the postoperative setting would yield favorable outcomes. Now we do have the results from Checkmate 274. This patient would have met eligibility criteria for Checkmate 274 based on receiving neoadjuvant cisplatin-based chemotherapy and having that adverse pathology at the time of cystectomy. And so certainly a strong option for this patient, adjuvant nivolumab administered for a year. So in early bladder cancer, immune checkpoint inhibitors have really changed the way that we treat non-muscle invasive bladder cancer with an FDA-approved therapy, are changing the way that we treat muscle invasive bladder cancer with the randomized phase 3 data demonstrating a disease-free survival benefit with adjuvant nivolumab, and certainly are poised to change the way that we treat patients in the neoadjuvant setting with a number of ongoing randomized phase 3 studies. Shifting gears to the advanced bladder cancer setting, the current status of treatment for patients with advanced bladder cancer involves first determining whether or not patients are eligible to receive cisplatin-based chemotherapy or not based on comorbidities, and then determining whether or not a patient's tumor harbors high levels of PD-L1 expression. And those 2 data points are used in most standard treatment algorithms. For patients who are eligible to receive cisplatin-based chemotherapy, cisplatin-based chemotherapy is standard. For patients who are not considered eligible to receive cisplatin-based chemotherapy, carboplatin-based chemotherapy is a standard treatment. There is the potential to use single-agent immune checkpoint blockade in select patients in that population as well, based on the available data. The level 1 evidence certainly supports the use of upfront platinum-based chemotherapy with switch maintenance immune checkpoint blockade based on the Javelin Bladder 100 study. Here you can see the overall survival benefit in the all-comer population and in the patients with tumors harboring high levels of PD-L1 expression based on the Javelin Bladder 100 study. At ASCO this year, we saw further analyses from this study demonstrating that this benefit does extend across subgroups of patients, including genomically defined subgroups of patients based on molecular subtypes of bladder cancer. So thus far, this seems to be an approach that applies to the vast majority of patients that we see who are eligible to receive frontline platinum-based chemotherapy with metastatic urothelial cancer. Another class of drugs that are really changing the way that we treat urothelial cancer include FGFR inhibitors. There's currently one small molecule inhibitor of FGFR approved for use in urothelial cancer, that is erdafitinib, and that's based on a large single-arm study demonstrating an objective response rate of approximately 40%. There are a number of potent and selective FGFR inhibitors in clinical development. You can see the response rates from various data sets shown on this slide. At ASCO this year, we saw an interesting result combining immune checkpoint blockade with the FGFR inhibitor regorafenib. And one of the reasons why this is an interesting approach is because this program, unlike the others, hasn't selected patients for enrollment based on mutations or fusions in FGFR3, but rather based on increased gene expression, based on increased mRNA expression of FGFR3. And you can see in this smallish data set the combination of regorafenib plus immune checkpoint blockade with atezolizumab yields a relatively high objective response rate. And this is in patients who largely do not have mutations in FGFR3. And this is in patients who largely don't have high levels of PD-L1 expression. So a small data set, but a very intriguing data set. And we look forward to seeing the results of this full study. Antibody drug conjugates really transforming the way that we treat patients with metastatic urothelial cancer, with 2 antibody drug conjugates now approved by the FDA. We have enfortumab vedotin, where the antibody is directed against Nectin-4 with MMAE as the payload. And we have sacituzumab govitecan, an antibody directed against TROP2 with SN38 as the payload. So 2 antibody drug conjugates, but different targets and different payloads, and potentially non-cross resistant therapies. The development for EV301 has included now a randomized phase 3 data where phase 3 study where we have level 1 data to support the use of enfortumab vedotin. The EV301 study randomized patients who had received prior platinum-based chemotherapy and prior immune checkpoint blockade, and patients were randomized to enfortumab vedotin versus standard of care chemotherapy. This study had an overall survival endpoint, and you can see that enfortumab vedotin was associated with a significant improvement in overall survival compared to standard chemotherapy, which included a taxane or vinflunine in parts of the world where vinflunine is available. So really reinforcing the results that we saw in the phase 2 setting with enfortumab based on response rate endpoints. Importantly, those response rates did hold up from the phase 2 to the phase 3 setting, where we see a response rate in this patient population in this large international randomized phase 3 study of 40% with enfortumab vedotin. And importantly, enfortumab vedotin was associated with favorable patient-reported outcomes compared to chemotherapy as well. So we have higher response rates, longer survival, better quality of life, certainly supporting the role of enfortumab vedotin as a key strategy in our therapeutic armamentarium. The Sasatisumab development program has thus far included a large phase 2 study exploring sacituzumab govitecan in patients with metastatic urothelial cancer who have received prior platinum-based chemotherapy and immune checkpoint blockade. And there's an ongoing large randomized phase 3 study testing sacituzumab govitecan versus standard chemotherapy. In the phase 2 setting, here you can see the waterfall plot showing the objective responses with sacituzumab govitecan, a response rate of 31% in this cohort of patients. And sacituzumab govitecan, also an important part of our therapeutic armamentarium based on the objective response rate in this patient population. All 3 of these therapies, enfortumab vedotin, erdafitinib, and sacituzumab govitecan, are associated with a unique side effect profile. With erdafitinib, you see as a class effect of FGFR3 inhibitors hyperphosphatemia, and you do see ocular toxicity, in particular central serous retinopathy. And so monitoring of phosphorus levels is required. Patients require counseling requiring dietary modification, and oftentimes phosphate binders are required. Patients should undergo a baseline ophthalmologic evaluation prior to starting treatment with erdafitinib. With enfortumab vedotin, we see peripheral neuropathy. We see hyperglycemia. In fact, that there's on the label a requirement to hold enfortumab vedotin for a glucose level of 250 or above. And we do see a rash, and the rash can range from a very mild rash to a more diffuse serious rash. So that requires vigilance and patient reporting. With Sasatisumab govitecan, an adverse event profile more consistent with a topoisomerase inhibitor, we see diarrhea and we see neutropenia. So in summary, there have been a number of key advances in just the past few years in the management of urothelial cancer, including patients with advanced disease, patients with clinically localized disease. We have a number of new therapies approved by the FDA. We have a number of therapies that are likely to be non-cross resistant, increasing the range of options for our patients. And we have a number of ongoing randomized phase 3 studies which will read out in the next few years, which are poised to change even further the way that we treat patients with metastatic and clinically localized urothelial cancer. Thank you for your attention today, and I hope this has enhanced your ability to care for patients with urothelial cancer.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MHH. This activity is supported through an education grant from Bristol Myers Squibb.